Welcome, everyone. Welcome back to those of you that were with us on July 20th, when we had the opportunity to do the, I guess you'd say, more general overview of the RADAR implementation, strength assessment, and quality of care tools session. Here we are starting off the first of a series of 4 deep dives into different aspects of these tools. And today's session is going to focus, of course, on intrapartum care. My name is Jessica Ferne. I am the Director of Global Health Impact here at CanWaCH. And as always, we're very excited to be bringing these sessions to you. As our Global Affairs Canada colleagues mentioned at the 20th session, July 20th session, when we were talking about it, these discussions are really meant to be an opportunity, of course, for us as Canadian organizations to become more familiar with the tools in terms of where they're at right now, but also, of course, to provide feedback. And this is a really critical time as the tools are being developed and refined for all of you here to share your thoughts, suggestions, and recommendations, particularly in these areas where you've got experience or interest. And I know I speak for our RADAR colleagues when I say that they're really eager to hear your thoughts. So this is meant to be a participatory discussion. You're all muted now, and we'll keep an eye on it in case there's a lot of background noise, but we are colleagues and this is a discussion among peers, so please feel free to take yourself off of mute anytime that you'd like to ask a question or add a comment. Don't feel you need to wait necessarily for a designated time, although I know we'll make sure that there are definitely key moments where we get to hear from all of you, but don't be afraid to just chime on in. So with that, I will turn it over to our colleagues at JHU. Just a very final word. This is I believe the project URL that you can visit, password radar 2020, if you want to log in and take a look there. So with that, I believe, Diwakar, is it over to you to kick us off?
Thank you, Jessica. And good morning to everybody. Thank you all for coming to this session for a deep dive on the Intrapartum tools. My name is Diwakar Mohan. I'm an assistant scientist with the Johns Hopkins School of Public Health. I primarily work in the field of maternal, newborn, and child health as an epidemiologist and quantitative research methods person. And I have my other colleagues on the call who I'd like for us to introduce. And after our colleagues, we'll probably go around getting to know a bit about each of you so that we can understand your motivations and your experiences with regard to implementation strength and quality of care assessments. So it would be fantastic to get to know all of you as well. I'll start with Melissa Marx. Melissa.
Hi, I'm Melissa Marx. I'm a PhD epidemiologist, and I've been doing evaluation of maternal child health and, of course, COVID response lately, as I think everybody has. But my focus since being at Hopkins, besides COVID, has been to really make sure that we figure out ways to collect data that can directly be used to improve programs and policy around maternal child health. So really happy to be here with you today to talk about intrapartum tools and methods.
Good afternoon, everyone. My name is Elizabeth Hazel. I'm an assistant scientist at Hopkins. I've also been working in maternal and child health evaluations for over 10 years now. I was involved in the intrapartum quality of care assessments that we're talking about today, but also I'll be leading the session on family planning that's scheduled for next week. So thanks very much for coming.
Cynthia?
Hi everyone, my name is Cynthia. I'm now a second-year master's student. It's nice to working with the team. Thank you all for joining. I hope you enjoy today.
So I'm just going to go down the list in alphabetical order. So just please let me know if I've forgotten somebody. I'll start with ABB. When you introduce yourself, could you just give us your full name, your organization, and some of your experiences in this area? And what are your expectations and plans for the radar tools?
Thanks. Thanks, Diwakar. This is Alia Bibi. I work with Plan International based at Toronto. I'm the Senior Health Advisor. And our portfolio is predominantly sexual reproductive health programs, which of course includes maternal newborn child health and family planning as an integral part. And as part of my portfolio, I provide technical assistance to most African countries in the region. And we've got some flagship programs in countries like Nigeria, Uganda, Ghana. And I'm really, we've been working with John Hopkins in some of projects also as partners. So I'm really looking forward to get more equated to these radar tools, because I think these really focus very well on looking at the quality of our projects moving forward.
Thank you very much. Unfortunately, I didn't catch your first name well at the beginning. Could you?
Yes, that's please? Alia Bibi. W-L-I-Y.
Thank you. Thank you so much. Can I move on to Charles?
Good afternoon, everyone. Charles Larson here. I'm a pediatrician and public health specialist and the interim director of the global health programs at McGill University. I currently hold a grant, a CanWaCH grant, where we're working on developing a maternal experience tool that will reflect quality of the labor and delivery experience from point of view of the woman herself, the recently delivered mother. Thank you.
Thank you. Louis?
Yes, hi everybody. My name is Louis Basil. I work for the Canadian Red Cross based in Ottawa. We work in two lines of business, mainly disaster management and supporting health services. And I work on the latter part. I've been working on that with supporting health projects in several countries on monitoring and evaluation, and since the inception on the planning too. Been interested in measuring the quality of care and the implementation strength of projects and ICCM since we started that in 2011, and benefited quite a bit from using these two tools for our project in Mali, and look forward to learn and about the other tools that was developed by Hopkins for intrapartum care, family planning, and nutrition, and benefit also from the discussion of the team for the ICCM part. Thank you.
Thanks, Louis. Leslie Dubin.
Hello, I am the research associate on the CanWaCH project that Charles just mentioned, so developing a tool on the childbirth experience. Yeah, that's it. Thank you.
Thank you. Naila?
Hello, hi everyone. Yeah, so my name's Naila, and I work as a consultant with Amplify Change, which is a funding organization that has various reproductive health projects across the world. And my role is a technical review panelist, and I review all the proposals on reproductive health, in South Asia. I've previous experience also working with Save the Children as well as UNFPA, and I've worked on various programs strengthening tools to increase the capacity of service providers on obstetric care. So I've been reviewing your site and all that, and I thought that this was something interesting. So I want to learn more about the radar tools and see what's all this about. Yeah, so I'm very much interested. So thank you for the opportunity.
Thank you, Naila, for joining us. Suzanne? Suzanne Powell?
Hi, Diwakar. Susan has posted her intro.
Oh, okay.
Yeah.
Okay. Thank you. Thank you, Suzanne. Tanya?
Sorry, taking me a moment there to unmute. My name is Tanya Saliski. I am a project director with Alinea International, formerly known as Agri-Team. And I specialize in the management of health programming with a focus on reproductive and sexual and reproductive health. And I'm particularly interested in these tools. I've just recently returned from 4 years in Tanzania, managing one of the GAC-funded MNCH projects on the ground. And we use some similar tools, including OSCEs and baby Natalies and so on, to do both training and skills assessment. And I'm particularly interested in how tools like this can be used to support good program decision making.
Thanks. Tasneem?
Hi everyone, my name is Tasneem Abdi and I'm a Health and Nutrition Project Officer at HealthBridge. We're an NGO based in Ottawa, and I'm also working on the same CanWaCH grant that Leslie and Charles mentioned earlier. Thank you.
Thank you. So I see one of you has joined us by phone. The number is 613-799-1402. Hello. Somebody who's joined by phone, 613-799-1402. Okay. Okay. So for the moment, let's move on to, when they get talking, we can probably introduce ourselves. We'll next move on to a short introduction to radar, because some of you have joined us for this session. So some of you have joined us for a previous session, and we have talked about these slides, and you're much more familiar with the radar project. So I'll give a quick overview of the radar project and what we are trying to do. Over to you, Melissa.
Thank you. Would you mind putting up the slide number 4, Diwakar?
Yep.
So a lot of you guys have heard about radar before. Some of you who attended our last session heard a little bit about what ISA and QOC are. You may have known already, or you may have heard a presentation previously by us. Diwakar, are you sharing? Great. Okay, thank you so much. If you heard that, or if you didn't, you've seen this slide. The goal of the radar project is and was, we're in the beginning of a no-cost extension last year of the project, to develop and test tools for evaluation maternal to child health programs. And the end goal of this project is to make all of these tools available so that anyone can use them to improve their programs and affect policy around improving programs on a national level. And GAC asked us to do this so that it was a little bit easier for people who worked on their projects to do evaluations and to use indicators and methods that were similar across different projects. So radar is comprised of many components, including there's a tool for estimating impact called LIST that you may have heard before. You can also predict what kinds of evaluations would have the most impact on a program even before you start. There's a tool called the coverage survey tool that is sort of like a smaller demographic and health survey, and you may have heard about that before. We are focusing on the implementation, strength, and quality of care tools that I've abbreviated here with ISA QOC. And in our couple years of the project, we have actually, as Louis said, we've worked with CRC and MRC in Mali to develop and then test out an ICCM tool. We've worked in Malawi with the government of Malawi and the National Statistics Office to evaluate family planning. And this is the work that Elizabeth will be leading a workshop next week on. The child health is the subsequent week. We also worked in Mozambique evaluating a nutrition counseling program that's implemented by community health workers. We worked with INS, the National Institute of Health, on that one, as well as our NGO partner, CARE. And then what we're talking about today, if you could click one more time, Diwakar, is our work in Tanzania on Intrapartum. Just click on the button. Yeah, nope, sorry. So our work on Intrapartum was in, we'll talk about it in more detail, but we worked with IFAKARA and we worked with AMREF on some tools to assess intrapartum care in Tanzania. Thank you. Next slide, please. All right, so I'm just gonna run through a few of these slides. You've seen maybe some similar slides before, but just to make sure we're on the same page. The real goals of implementation strength and quality of care evaluations are to identify strengths and gaps to inform improvements in program implementation and to inform policy review and changes if necessary. That's the first and most important thing we think that these tools are useful for. But you can also see it as an evaluation of the program as a whole. You can use these tools to determine whether a program can provide care at a level high enough to impact health. You can see if poor quality of care or weak quality of care in a particular area is maybe reducing the impact of a program. And then finally, alongside of the other tools that I mentioned, ISA and QOC evaluation tools and methods can actually support evaluation findings. If you find that your coverage or impact or modeled impact of a program it doesn't seem like the coverage has changed and it doesn't seem like there's impact, you may be able to figure out why with your implementation and quality of care results. And similarly, if you do have success, the high implementation strength and quality of care results, or the positive results that you might see, the strengths that you pull out from these tools, can really add to your inference around whether it was improvement in the program, improvement in health or impact was associated with the program, even if you don't have a randomized controlled trial. The next slide, please. So, sorry, can I just have a moment, guys? I'm in the middle of something, okay? Sorry. I'm sure everybody's has kids around them now. So the next thing I wanted to just make sure we were on the same page, because implementation strength is something that we have used and it's in the literature to some degree, but I just wanted to make sure we were clear on what we mean by quality of care and implementation strength. We think of implementation strength, we think of quality of care, and we focus on the technical quality aspects and the degree to which health services increase the likelihood of desired outcomes that are consistent with current professional knowledge. Go to the next slide, please. And implementation strength, we think of as readiness to deliver services. In the Donna Bedian lexicon, we think of that as structural quality, but even more, we look at whether our programs are also stimulating demand for the program as well. We also tend to think of this as the dose of services that are available. And the implementation of strength, some of the domains we think about are accessibility and availability, infrastructure, commodities, and personnel. Next slide. So you may have seen us show this impact model before. You have certainly developed impact models before, but I just wanted to reiterate where our tools fit on this impact model. Our lexicon is, our wording for this is we talk about inputs through impact, but I know that GAC really talks about ultimate and intermediate outcomes. Same kind of thing here. This is just a model, impact model, just for example purposes. Could you go to the next slide? We think about impact models as answering different questions, as helping us to think about different questions for evaluation. And one more click. And with implementation, strength, and quality of care, we're really focused on is the program being implemented as planned at sufficient strength and quality to achieve expected impact. And so that means we're sort of in the middle of the impact model. We're thinking about activities, as we call them, and outputs. And some of the questions that are posed that can be answered by implementation, strength, and quality of care tools are, does the quality meet technical standards? In what technical and supply areas could there be improvements, and is care significantly better in the intervention group compared to a comparison group if you happen to have a comparison group? One more, next slide. So a lot of people we've talked to have wondered which radar tools are appropriate for use for their programs. And we have several methods that are used with each of these tools that are listed here. And the decision about which radar tools to use, next click please, are really related to really what are the goals and objectives of the actual program. Are you looking at all three of those goals that I mentioned? Policy and program goals, strength of evaluation. You really have to take a second and figure out which, and maybe you're interested in all three. You want to affect policy, you want to affect implementation of the program, and you want to strengthen your evaluation, your ability to infer causality with your evaluation. And then second, what specific evaluation questions are you trying to answer? And some of those I listed a second ago underneath the impact model. But there are other ones, specific questions that you'll need to answer, that you'll want to answer. And then the last thing is other considerations. So implications of getting it right or wrong. So what I mean here is sometimes it's life or death. If the technical quality is bad, then a patient or a baby or a mother in this case might die. Sometimes it's just a message might be imperfect. Then the other consideration is funding and resource availability and feasibility of using the different tools. So it's not straightforward, and you do have to consider all these things. And I'm gonna now hand it over to Diwakar to talk in a little bit more detail about the IP tools and how decisions might be made around what methods and what tools to use for intrapartum care evaluation. Go ahead, Diwakar.
Thank you, Melissa. Carrying on from what Melissa has talked about, about the questions that we want to answer as part of the quality of care assessments or the implementation strength assessments, like when we focus on quality of care, we kind of get into a couple of different ways of posing these questions. So if you want to know what happens routinely, the possible question is, do providers perform to standard in their routine practice, whatever intervention or counseling that you expect them to do? If you want to know what is the best possible level, kind of the ceiling, and the question that you want to pose is, are they capable of providing to standard when they know that they're being observed? So, because usually we know that providers kind of can perform certain things that they wouldn't usually perform in routine practice, especially if they know that they're being evaluated or being observed by a third party. Then the next is competence. Do they have the skills required to help them perform to standard? Because in many instances, it may not be possible to observe them perform to standard. So the next best thing we could potentially do is, do they have the skills to perform to standard? And similarly, knowledge. Can providers actually say or write down, at least in theory, what needs to be done? Like, this is kind of our simplest knowledge test, where we can ask them specific questions about whether they know a certain aspect of care or not. So, what are the qualities of an ideal method? Ideally, we want them to be done on real patients. We want them to be gold standard, as in saying that if this assessment is good, then it's the best possible thing. And providers don't know that they're being evaluated. We get complete and valid information. And obviously, we want to do all this with very little cost and complexity. But unfortunately, this is kind of a utopian dream, and we don't have methods that kind of do this. So in a way, we are forced to kind of move into methods that get at some quality, some aspects of these, and some that they don't. It's going to be a trade-off of risk versus benefit, basically. So a few of the key assessment methods that we are going to be kind of looking at today, we've quickly jotted down some of the benefits and their limitations, and we wanted to quickly run through these before we actually move into these tools, so that we have this in mind when we are looking at these tools. So we start with direct observations. The direct observations, it shows what they do in a real life clinical setting, and kind of it gives you the best impression of the process quality as when it is measured by a clinically trained observer. And it can help us to identify any serious errors or deficiencies. The unfortunate limitations are that the provider knows that they're being observed. So it is likely to influence some of their practices. Like, they do things that they don't usually do, or in many instances, they don't do things that they usually end up doing in actual practice. And these are quite expensive and complex to do. And we need specialized observers who must be trained in the kind of services that they're evaluating. And more importantly, it's very difficult to do it in places where we have very little volume of the services that we want to observe. So, and more importantly, it needs to be scheduled ahead of time, which kind of goes into the complexity of different things. And also, in many instances, it compromises the client's comfort and confidentiality. The clients may or may not want a third person to be observing what they're doing. So, an alternative to that is observed and simulated services that are done with you, in many instances, patient actors, or with simulators, dummy models. One of the benefits of this is it addresses the issue of observation in low volume services, like kind of giving us a chance to observe things that are usually not possible or very difficult to observe. And clinical, so some of the limitations are, again, the same how the effect of being doing things when you're being observed. So providers perform to the best possible ability for different things. And again, we need very similarly clinically trained observers, and some of the quality aspects are very difficult to gain from just these simulations more than actual real life settings. And there are some costs involved with these simulators and models. Facility aspects typically get at the concepts of structural quality or readiness or implementation strength, as we were talking about, and some aspects of process quality, like the availability of, say, trained providers. These are usually easy to complete by the interviewer, and many instances these are done even by even done remotely by phones. But there are a lot of limitations as to what these methods can and cannot measure, basically. And the next assessment method is the client exit interview, where patients are kind of interviewed at the end of their clinical interaction, usually out of range of provider. So the benefits of this is this gets at the quality as perceived by the patient. So in a way, it kind of gets at what do they think of the quality of the clinical interaction that they just encountered. And this has been very much used in family planning, because it allows us to get at things like their availability of choice, but it is quite restricted in many other settings like intrapartum care, where a lot of technical quality is involved. And again, the limitations are still about sample size, client volume at facilities, and everything depends on how much can we do within the available resources that are available to the program. And more importantly, there is also the social desirability bias, and especially when clients think that they are unable to speak their mind, because many of these assessments are carried out still within the grounds of the facility. So some of these barriers still exist. Provider surveys, these are direct assessments of providers, and we can do these using case vignettes or direct knowledge tests. And the benefits is, it also kind of, you can get at some of their knowledge and also their attitudes and biases that might influence care. You can use this very quickly to assess multiple range of services and look at any correlations with the provider's characteristic. But as we know, one of the key limitations is that knowledge does not actually equal practice. So it does not actually equal quality. They may be correlated, but they don't exactly go together in many instances. And there are still difficulties about what's the best way to do these things, and they may not be easily comparable if we are doing many of these across different countries and geographies, across different cadres of providers. So I'm going to take this opportunity to actually walk us through some of the tools that we have as part of our as part of the radar suite. As you all know, Jessica posted the link for this specific website in the chat window, and the website is isaqocfeedback.com/ipcare, and I've previously shared the details in my email along with the password. So please feel free to open up the websites on your laptops and kind of go through it as I walk you through some of these tools.
Diwakar, can I jump in for a second?
Sure.
Maybe folks can let us know if they've looked through the tools, and if they want to post a chat in the chat box, or just let us know if they've looked through them, and that way we know how much detail to go into. If we don't hear from folks, we'll just kind of start going in depth about them. If anyone wants to just chime in at any time, they should feel free to stop us. And I just want the opportunity for you guys to talk, to be there, and to remind you of that.
And just to note, this is Jessica here, just to note that we have reshared the link and password in the chat. If you are having any difficulty accessing it, just let us know.
Thank you, Melissa and Jessica. So to help with everything, I'm going to be sharing my screen as well to kind of walk folks through the websites. I apologize. There may be folks who are joining us by phone and may not be able to see what I'm showing, but I'll try to describe in detail what's happening here so that people on the phone can follow through as well. But just to reiterate, the website is isaqocfeedback.com, isaqocfeedback.com. And if you can follow us on your laptop, that would be fantastic. So this website, we have a homepage that quickly gives you broad details about radar and what we've been trying to do. And we have tabs for each of our areas that we're going to be doing these deep dives into. And today we're going to be focusing on the intrapartum care area. So as a quick introduction, we use these tools and tested them in the setting of a region in Tanzania called Simiyu. Our primary objective then was to evaluate AMREF's Uzazi Uzima program. And AMREF was working in a lot of components of safe deliveries. A lot of basic emergency and obstetric care, comprehensive emergency obstetric care, and community-based health workers as well. Our focus was specifically on the BMONC side of care, because we were focused on trying to test these tools for BMONC, because comprehensive emergency care, they do require a much more specialized set of tools that are not easily customizable and testable in such small settings. Just a reminder for folks, BMONC is a collection of services provided in emergency situations to handle childbirth and delivery. It comprises of these signal functions. We quickly, we had this introduction webinar in July, on the 20th of July, and to which many of you attended. And today's session is about these specific tools that we are going to be reviewing. And each of these tools are linked to this bolded text. So we have about many tools listed here. The first one is about implementation strength assessment, which is primarily the facility assessment and any interviews with the health facility workers. Then case vignettes, which are clinical scenarios that we expect providers to face during the routine care, and we expect them to walk us through their process of managing such scenarios. And we have 4 scenarios. One, normal delivery, where all the parameters are within normal boundaries. We have a preeclampsia management scenario. We have a postpartum hemorrhage management scenario and a neonatal resuscitation scenario. We focus on these 3 important complications because these are some of the most commonly seen ones, and we feel that these are the ones that they've been trained a lot in as part of their training packages. We also have a quick read of instructions on how to test and, if necessary, change some of these clinical scenarios based on your individual context. So if you go through these instructions, you'll get a quick idea of as to how could you potentially modify some of these scenarios to fit your needs. Finally, we have the direct observation tool, which is, as its name says, like kind of a checklist of observing a woman in labor and delivery. So it starts from the time of admission and kind of ends at about immediate postpartum period, just beyond the period of observation of following a delivery. We have some additional resources for these kind of assessments, and these are assessments that these are potentially resources that could be used for any kind of such facility-based and quality of care assessments. Please feel free to explore any of these tools, and in case you have any queries, please do email us, and we'll be more than happy to clarify and kind of walk you through some of these easily available resources. And for more information on how we use these tools and how we tested them and what are some of the results, you can see the research protocol that went into the institutional ethics board for accompanying these tools, and the final report produced after the end of the evaluation. So these will give you a kind of a brief idea about some of the tools that are available and readily available, and for people to use as a template when they start doing some of these assessments. So I'll briefly pause here and see if there are any questions, any comments, and anything at all that I can actually clarify. I'm going to actually, are there any raised hands? Any? Okay.
I was just wondering, will we get an opportunity to do kind of like go through an example or something to like a hands-on kind of an opportunity to go through the tool itself? I'm sorry.
Yes. So that was my next step. I'll be going through each of these tools to kind of walk everybody through some of these tools actually as well.
Okay. Thank you.
So if you click on each of these links, it'll take you to a Google document page where you'll be able to kind of look at each of these tools. And over the next few minutes, I'm going to be actually walking you through some of these tools as well. I'm going to walk you through each of them section by section. Does that answer your question, Nyla?
Yes, thank you.
Yeah.
Thank you. Thanks a lot.
So basically, looks like there are people who are very eager to look at the tools. So I'm going to be starting with each of these tools in turn. So I'll start with the implementation strength assessment tools.
Excuse me.
Yes.
Is there any link for the final tools? I've worked with you in developing some of these tools for Tanzania, but I don't. Apart from the Google Drive we had, is there any resource center where we can have the final tools? And as said by Melissa, we can use them for our programming later on.
Sure. Frida, right?
Yes, Frida.
Oh, hi, Frida. So you're able to download these from the Google website. So you can download it there. But if you need Word documents, please feel free to email me. I'll send you the Word versions as well.
Okay, perfect. Thank you.
Okay. I don't think there are any restrictions to downloading it from the site. Is that? I don't think so. But if you feel that it's better that you get a Word document version, I'll be happy to send them to you as well.
Perfect. Thank you very much.
Okay. Thank you. So it's the same thing for all of these resources. Any of these tools that you feel that you're not comfortable looking at it on Google Documents, or you want a Word document with its original formatting, feel free to email us and we'll be happy to send you those tools. They're right now in the draft stage because we are yet to incorporate the feedback that we'll get from you. And so we want to make sure that you understand that these are draft tools at this point in time. Thank you. So I'm going to start with the health facility assessment and the provider interview tool. And as I previously mentioned, we work with AMREF to kind of do the assessment. So feel free to stop me at any point in time. And there are some key points where I've kind of identified potential areas for discussion, just in case people might want to pause there and kind of discuss a certain point or any area of concern. Feel free to stop me wherever you want. It's not necessary that you just need to stop me at this discussion point. Feel free to stop me at any point. Please unmute yourself and kind of express yourself by words. Because I won't be able to see the chat, and if somebody has typed in questions, I wouldn't be able to see it. So
we'll also monitor the chat as well.
Okay,
so if for whatever reason can't come off mute, feel free to type it in the chat and we'll interrupt and ask it out loud.
Okay, thank you so much. So the discussion points that I've put in here are some of the questions that we have had when doing some of these assessments, and to make sure that we are getting at some of these indicators in the right way. So for example, as we previously mentioned, the implementation strength, we cover a wide variety of domains like training and training, supervision, commodities, and availability and accessibility of these for care. So one of the first questions that comes up is, who provides intrapartum care at a facility? So the one thing that we've seen is, in many facilities, a lot of providers end up providing intrapartum care, even though only a few of them are technically qualified to provide care. So for example, a medical assistant who's probably not usually considered a skilled provider has been working at that facility, and that facility doesn't have a choice in many instances. And these things, so do you include them or do you not include them? So that's a key question that we should probably consider as well. So we go in favor of not including them, because one of our key aims is to look at how ready are facilities to provide intrapartum care, and we feel that including non-skilled providers in this list would kind of not be fair to the goals of the program or the objectives of the program if it includes training as well. We start with the general listing of all the providers who provide intrapartum care, and it's useful usually to know it by cadre, because that lets us quickly get this list down, and also for future stratified analysis if necessary. And we move on to then the supervision of the facilities. We talk about what was their most recent supervision, and we kind of try to use this in terms of whatever is required for that particular context, basically. If they are required to have a supervision at least once a month or once in 3 months, we basically want to benchmark it against that. We also ask for availability primarily, which is how many days of care are there per week. So these are some of the broad areas in which we get it. So if you move through this document, you'll be able to see some of each of these domains that we have addressed previously. So I'm going to quickly move through these documents so that it just gives you an overview of what is available in there, and feel free to stop at any point in case you need to ask a query or clarify any issues. But otherwise, I'd probably keep moving through this and potentially stop at some few points that I think might be worth a discussion. So once we ask about the availability and practices at each of these facilities, we then move on to the availability of certain things at these facilities, like supply equipment and commodities, power, water facilities, different kinds of toilets. This is especially key for gender-sensitive interventions, in that there are available facilities available for women to use exclusively at some of these facilities. So it may be of importance. And beyond this, we have about the different kinds of equipment that we need for the different aspects of intrapartum care. It includes complicated ones like the ventos and manual vacuum extractor, and also even the simple ones like whether they have appropriate waste receptacles. Then we move on to other equipment that includes sterilizing equipment. Then we specifically focus on some of these availability of these guidelines, because we feel that when guidelines are available, that's kind of is kind of a good step in ensuring quality care provision. So we ask about different kinds of guidelines that are posted. I know many facilities may have a guideline, but there's no written document, or there's nothing verbally, there's nothing written down or available for the workers to refer to when they need it. So what we are looking for is available guidelines and different kinds of supplies. And then we move on to drugs. And for drugs, we primarily look for drugs on the day of visit. So we want to make sure that the day of assessment, that the facility has a drug that it can actually use when required. And these can be modified according to the kind of drugs that are used in different contexts. So, for example, we have focused here on oxytocin and ergometrin as neutrotonics, but in many instances, it's just oxytocin or just ergometrin. So depending upon what the context is, these can be modified. So there's an entire list, and you may find many of these lists very common, like very similar to what we have in the WHO SARA kind of assessments. These are not very different from them. And then we focus on referrals as well, like kind of trying to get at what is the referral functionality available at the facility, about a vehicle that is available for referral, and do they have protocols that's for referral. Then we want to data use. Some of these may be not pertinent to direct care delivery, but are useful functions that are necessary for the optimal functioning of the service delivery points. So then, since this is intrapartum care, we also look at some of these quality improvement activities and team activities that are done at the level of the facility. Then we move on to individual provider assessments. Usually these provider assessments are made of each intrapartum care provider who's available at that facility on the day of assessment. So for extremely large facilities, you may end up interviewing quite a lot of providers. For very small facilities, this will be a very small number, or just the same person who does the facility assessment previously as the in charge will probably end up being the only provider available as well. So again, this focuses specifically on the training. And here we are focused on some of the trainings that are closely related to provision of emergency obstetric care and essential newborn care. So these may be modified based upon the kind of training that's being evaluated as well. And in many instances, they have completely different names, although they refer to the same aspect of training. So one needs to kind of modify some of these wordings in accordance with the context. and this ends with their supervision. So this is a quick overview of the implementation strength tools, which is the facility assessment and the provider interviews. Again, I'll quickly pause here for any questions, any suggestions, any feedback. Okay. Looks like it makes perfect sense to everybody. That's good to know. Thank you. So I'm going to move on next to the what we call the clinical scenarios, the scenarios that we use to test provider knowledge and skills in situations. The key point about these tools are that we in Tanzania tested them under two different conditions. One was using the Mama Natalie dolls as and simulators to help providers walk through these scenarios using those simulators. And we also tested them without the simulators. We asked them to imagine that this was a situation that they were facing, a hypothetical situation that they were facing, and asked them to kind of walk us through each of the steps that they would take and kind of voice out what things that they would do, how they would do it, and kind of walk us through the entire process, basically. So the availability of the dolls and the simulators kind of provided them a visual cue and frame for some of the things that they did. But when we did the clinical vignettes, this framing and visual cues were absent. So basically they would have to imagine it really well in their minds and then walk us through the situations. So each of these assessment methods has their own peculiarities in how people respond, how providers actually responded to some of these scenarios. One thing that we would like to emphasize is that although we've created some of these scenarios, we think that some of these scenarios may not fit certain contexts, or the procedure for certain one of these things might be completely different in a different setting other than Tanzania. We are hoping that these are common threads that could be used elsewhere, but it would be good to kind of again test them in these settings before you start using them. This will give the evaluators a bit of familiarity with how to use some of these tools as well, and to modify the tools based on their initial pre-testing and pilot testing. So we provided some brief instructions for how to go about testing these scenarios. These are quite brief, and the reason that we've kind of provided them are to make sure that folks understand how this testing needs to happen. Like, what do they need to do this kind of testing? So once this testing is over, again, I'll probably pause here to ask for any quick, if there are any quick comments or questions. If not, I'll move on to the clinical scenarios.
Diwakar, I have a question about the scenarios. The instructions as you read the scenario, and is it then you observe the actions of the interviewee, or it's about or verbal answers?
So, quickly to clarify, this is the instructions for testing of the scenarios. What we mean by testing of the scenarios is to as a pre-testing and pilot testing before the actual assessments, you want to test out whether these scenarios are capturing what you want to capture as part of knowledge. So kind of adapting our tool to your context, basically. So these basically refer to those instructions.
Okay, thank you.
So basically what we would call pre-testing or pilot testing.
Okay.
So because see, including the names, ages, some of these things would need to be slightly modified in certain settings, because in every setting there are all these connotations that we don't even realize, that we don't want the provider to focus on something completely different that we are not intending to ask at all, and like they might get sidetracked by what they're planning to do. So just to make sure that people are not sidetracked and they're using the right choice of words, we want you to kind of test out these scenarios in a limited manner, like testing it out on a few providers before you actually finalize your tools and use it for the actual assessment. I hope
Thank you.
that made it clear about the purpose of this particular sheet. Thank you. Thanks, Louis, for that question. Like, it's good to know that was his confusion.
Diwakar, can I come in as well for just a moment?
Please.
It's Tanya Saluski. We used hands-on practice stations in multiple facilities. We use these essentially OSCEs to both train and assess healthcare workers. And in the Tanzanian setting, we found that often the scenarios were written up in English, but we had to translate them to Swahili because many of the staff were conversant with English on a certain level, but they would always play out the scenarios in Swahili. They couldn't do it in English, and it was easier and better understood for everyone when it was translated. So I would caution that while you can develop your scenario in English, depending on your context, you'd really want to make sure there's a consistent translation. And we found we had to do a formal translation of the tools because while they were written up in English in practice, everyone was translating them. And so we couldn't get a consistent result from the tools until we had actually formally translated them. So all of our testers were using the same words in Swahili as well. Otherwise, it wasn't a consistent result.
Even our assessments were carried out in Swahili. These are just, so that's probably part of the pre-testing process as well, like the use of the right words. Like once we translate it, we then pre-test it and pilot it just to make sure that the right words are being used at every instance.
This is Melissa. Can I pose a query to the group? About translation, how have you guys handled situations where there's a spoken language and not a written language? We experienced that in Mozambique, not on IP tools, but another topic area. Does anybody have experience with that?
And even in Tanzania, even in this setting, we had the situation because our tools were in Swahili, but some of the population in Simiyu spoke Suguma. And so, although we didn't have explicitly translated tools in Suguma, we still, we had speakers in the team who kind of spoke Swahili who ended up translating it. So what Melissa is describing is something that we've experienced in multiple settings, actually. Thanks, Melissa, for raising that.
I think I can speak to our experience. We have witnessed that sometimes in one country there is more than one spoken language, and if the tool is in English or in French, then the only way to do it is spend enough time at the training and translate that verbally at the training and make sure that the data collectors have mutual understanding on that particular language. But at the end of the day, it's going to be, I think a considerable factor in the limitation of the study.
Yep.
Thanks, Louis.
Thanks, Louis. Like, I know many of these instances, we've spent more time trying to make sure that we are conversant and we're conversant with the issues of the language during the training process. Trying to get at least some people who know that particular language as part of these teams that do the assessments. Tanya, any other thoughts, any other questions? Like, just to emphasize that we did our final assessments in Swahili, but just the English is just for sharing with the wider group.
No, nothing else from me at the moment. I'm sure I'll have other things to say later.
Yeah, please feel free to chime in at any point in time.
Diwakar,
Yes?
we have a question in the chat from Susan here. I just read out the question. Okay, here's a question regarding B11. If the provider does not provide interpartum care at the facility, why are they being surveyed? Should they continue the survey if they don't offer care? And also, should like to hear if there is any experience or strategies used to measure more than one provider's training and supervision.
Sure. So that's a good question. So this is, the provider assessment is usually nested within the broader facility assessment. So the question, the reason that the question exists here on this tool is just to make sure that the enumerators are quite strict about whether they figure out whether a provider does provide an intrapartum care. Again, they check with the provider again saying, okay, do you provide intrapartum care at this facility? And some instances, the facility may be so big that the in charge may have given them a name and he might have forgotten that this person does not provide them care anymore. So this question just exists to filter out these people who probably say that they do not provide care. If they do not provide care, we stop. We don't continue to interview this person for this tool. Does that answer your question, Susan? Okay. I'm unable to go to the chat window, but please somebody let me know if she says yes or there are further follow-up.
Yes, yes, that answers it.
Okay, thank you. So the key point here is, so for reasons of good measurement, we want to kind of make sure that we explicitly state some questions out loud, even if they're kind of taken for granted, so that our subsequent data entry forms and everything have that, you can use that to make sure that good data is collected. So that will be the reason for many of the questions as well. Some of the questions, even if they don't make the best sense. So as I said previously, these are those were the testing instructions. I previously walked you through the testing instructions for the case scenarios. Now these are the instructions when somebody does the assessment. So these are some brief instructions for the OSCEs and brief instructions for the clinical vignettes. The reason that we provided them in brief here is to kind of make sure that every time before an assessment, the assessor actually walks them through some of these instructions, just to make sure that everybody understands them well and everybody's on the same page. So the assessor also needs to be quite conversant with these instructions before they start the assessment, so that they're comfortable explaining it to the provider as well. So this scenario is about a normal delivery. We've provided a brief description of what happens, and we've tried to make sure that each of the parameters that we have provided here, make sure that none of them raise a flag. So we say she's 38 weeks pregnant. So just to make sure that this is a completely, neither preterm nor postterm. So each of the measurements are completely within parameters, just to make sure that nobody gets, we don't want these red herrings that providers follow and kind of go down some other pathway that we don't want them to. So we just want them to imagine a typical normally laboring woman that comes to them, and we want them to walk us through each of the steps that they would take right from the time that the woman walks in to the time that she's moved to the postpartum ward or so. So this is a quick description of the scenario, and the instructions for the provider are what are the steps that they would take. I know these instructions kind of make it very they seem very short, but in a way, the objective is that the assessor should kind of make them understand what exactly is required of them. Like they could even do one of these scenarios as a practice scenario before they actually do the assessments, so that the provider feels much more comfortable in understanding what is expected of them. Because as we know, like anytime we face an assessment for the first ever kind of modality of testing that's we've never ever seen before, we make some mistakes just because of the modality of testing rather than actual content. So it would be good to kind of walk the providers through a practice scenario. So during our assessments, we actually used a pre-eclampsia scenario to actually walk them through it, the entire scenario and what we would expect them to say at each of these stages. So they would, the assessor would actually pretend answer some of these questions and help them think through the process. So after that, then we shifted to the scenarios which were used for the assessment.
Diwakar.
Yes.
Alia here. Just wanted to add some of my experiences in using these, not to take the limelight away from evaluation, but following on what Basil was mentioning before, making these checklists part of the training. And then what we did was also in some of our projects where we talk about supervision, we bring in these checklists to the supervisors who then uses them as part of their mentoring and supervision visit. So they pick up these scenarios, they walk through with them, so that at the end of the day, when it coming evaluation day, this may not look like a totally new thing for those providers also, and they are more comfortable and hands-on on going through the process too.
Perfect. So you're saying that this is also, what you're saying is that these kind of scenarios can also be a kind of a supporting mentoring tool.
Exactly.
Yeah. Yeah.
Can I come in as well?
Yes.
With something from our experience, we developed a series of scenarios. Essentially, we called them case cards, and they were used for ongoing mentoring and for peer mentoring. So, in the initial training, we actually trained multiple people from different facilities to work as a team or to work in pairs to do a scenario with each other. And so there was a small flip chart with a scenario on one side, picture and some basic stuff on one side, and then the scenario for the peer facilitator, and they would work in pairs to practice a scenario and then switch places. So each peer learner would have the chance to be the facilitator and the learner, and that was seen to be a very effective way of ongoing peer mentoring. So it wasn't always someone from the project staff who was doing the mentoring. They could do this themselves in their facility when they had an opportunity to practice. And we found the case cards were great. It was the setup around who's going to practice, when are they going to practice, who's going to make sure they practice. That was always a bit more of a challenge. But for the testing, when we did assessments of learning, we used the same or very similar cases. So I think just to echo what the previous speaker said, you can use the scenario to test. You can also use it if you develop it into a really simple kind of case card with the different roles on the opposite sides of the card. You can use it for peer mentoring as well, or for supervisor mentoring. The same would work. One challenge that we found when we were using it as an evaluation tool was that evaluators would evaluate very, very differently. So two people could watch the same scenario with the person who was being evaluated, making certain mistakes or whatever, and come up with very different evaluations. And we had to do a full 2-day training with our evaluators, our assessors, to make sure that there was an appropriate level of consistency across the group of assessors. Because it was quite an endeavor to assess a large number of people, and we needed to make sure that there wasn't one person who always gave everyone a really good score and others who would mark much more hard. We wanted a consistent level of evaluation, and that was a huge challenge and something we didn't quite realize until we were in the process of starting the evaluations, and then said, wow, this is hard. We're not getting the same, we're not getting a level field here from our assessors.
Yep. Thank you for that insight. Like that's actually very true. Actually, like especially this might even depend on the differences in the skill level and the qualifications of the evaluators themselves as well sometimes. And so one of our ways that we coped with this was to, as you said, train them intensively, provide them repeat practice sessions, and provide them feedback. The other was to kind of make sure that we split up the checklist into as small pieces as possible, like kind of trying to go through each of these steps that they would probably have to mark rather single action and putting it down. So we kind of broke down every interaction into individual pieces that they would have to kind of check, mark on their checklist. With a lot of training, but again, one of the things that around designing a tool, how could we potentially minimize that?
Sorry, Diwakar, it's very choppy for me, and I'm just wondering if others are experiencing the same thing. Melissa?
Yeah, Diwakar, you're going in and out.
You're breaking up, Diwakar.
Yeah, so maybe, does Diwakar, do you want to just pause for a second? Can somebody else from the JHU team come in?
Sure. Yeah, I mean, I think I kind of lost Diwakar's train because of the choppiness. But I think some of what he was talking about, if I can pick up from there, was around assessment. And I guess one thing that I was thinking about as we were talking about this, which isn't probably where Diwakar was going, but was when you train on an exact scenario and then develop your evaluation based on that same scenario, are you getting a true evaluation of the capacity and technical or knowledge and getting towards technical quality and comprehension of that healthcare worker? Or is the practice sort of artificially increasing the ability of that person to respond to that scenario? And so I wonder if this, and you know, I agree that that it's variable how the person who's assessing the quality of care can be really variable and requires, I think Diwakar was saying, very small chunks. So you're asking about not did they do something well, but did they do this little step? Did they do this little step to get it as objective as possible? But I agree, you're always going to have some subjectivity. But I wanted to pose the question for the group: do people feel like doing the evaluation itself based on a scenario that has been practiced is, you know, what are the pros and cons of that? And are some of you guys advocating practicing on scenarios, but then using an alternate scenario that may cover some of the same issues, but is not something they've practiced on in order to actually get a feel for the quality of care? I'll stop there.
Thanks, Melissa. And just noting here, although this might tie into it, some questions that we have in the chat around maintaining confidentiality and capturing respectful and supportive care. Diwakar, are you back? Do you want to?
I'm here. I've actually switched off my video just to make sure that it's not my data connection. So
excellent.
So I hope people can hear me okay right now.
Yep, I can hear you clear, loud and clear.
Okay, thank you.
So that's great. Again, turn it over to anybody else who wants to ask any other questions in the chat or has any feedback to what Melissa just shared.
So one of the things that, based on what Melissa said, is one of the key points that usually do not come across in these kind of simulated scenarios is how respectfully or empathetically as a provider treat the patient. So that is kind of very difficult to capture here because either they're dealing with simulators or in many instances they're trying to imagine the situation in their mind. So some of those kind of questions, are not captured. So it will be very difficult to assess whether they're able to provide emotional support and reassurance. So just to keep myself on track for time, I'll just move on to the next scenario just to walk everybody through each of these different scenarios. The normal delivery scenario was quite comprehensive in that it started from admission, spend time on the part in the middle of during the second stage of labor and third stage of labor, and finally into the postpartum period. The preeclampsia, each of the complication scenarios are kind of slightly smaller and take a shorter time to administer in terms of the length of the tool, primarily because they cover these different aspects that start management of that particular complication. So we have one for severe preeclampsia management, and we have another one for postpartum hemorrhage that starts after delivery. So the scenario itself begins with a woman delivering and then kind of asks the provider to list the steps of what they would take after that. Similarly, the neonatal resuscitation would start after delivery and from there starting to assess the newborn, basically. So each of these scenarios is available on Google Docs. Feel free to use them, feel free to download them, feel free to provide feedback individually on each of the items available out there, so that if you feel strongly about wording something in a particular way, please do let us know how you would like to do that. So quickly coming on to the last tool, this is the direct observation tool. Many of you are familiar with the direct observation tool because this has been very commonly used in multiple scenarios. And we've kind of tried to create a tool that is simple to flow, especially once you put it into an electronic data collection format with the skips and everything. So it's much easier to skip certain sections if they don't happen, or to capture multiple births as well. So in case there are multiple children, you get to address some of these questions for each of those children. And as we know, there are multiple examinations of a woman that may be done over the entire duration of her stay at the labor and delivery room. So there are options for entering each of these interactions in like the number of, for each vaginal examination, one could potentially record what was done and what was not done as part of that vaginal examination. So the entire tool kind of flows to kind of make it easy for administration when using both the electronic format and in a paper format. So coming back to the other, before I move on to the other tools and other additional resources, do we have any questions on either the clinical scenarios or the direct observation tools? Probably.
I have a question, Diwakar, about the scenarios. The instruction says that the data collector will read the scenario and could repeat it more than once for the participant. But considering that some scenarios may have a considerable amount of information and numbers, is it possible to give the scenario to the participant to read, especially if the
you can print out these laminated cards that can be used and kind of provided to the scenario, the provider who's doing the scenario. So they can quickly walk through the scenario as well. So another thing, idea that would be good to do is for some of these scenarios, we also can provide them with a sample ANC card or even an actual clinical record file. Something that records what has happened and what's the what has been recorded about that patient until now as well. So that to give it a natural feel about it. But it would be easy to actually laminate some of these case scenarios and give it to the provider for them to refer to it whenever they want.
So there are different ways of administering it and not necessarily only through reading.
So the scenario is only the information that needs to be provided. Either the assessor can actually read through some of these, or they can read through them and also give them a card to provide them a quick reference back to it, just in case they don't want to keep repeating the same information again. But the provider is more than welcome to ask any of these questions back again, asking them, okay, what did you say the blood pressure was, or what did you say the pulse was, or something. If they want to clarify something, they're more than welcome to actually ask the assessor again, or even maybe to make it easier, if we have a laminated card that kind of lists out the scenario, they could refer to it again.
Okay, thank you.
It's basically to get them oriented to understanding the scenario. Sometimes the specifics may not matter much in terms of actual values, but beyond the point of actually putting the provider in the moment, right? We want to put them in the moment of that situation, like trying to create that as close to their clinical situation as possible.
One more question. Will you speak during this webinar later about the experience of the pilot of the vignettes, and how did it go, and maybe did the process change from the ICCM that we did in Mali or not?
Yes, so I could very well talk about it right now. This is probably a good segue into discussing that. So some of the people also, we will be touching upon some of these issues in a later slide about how to do these logistics. So we were quite happy with the way that we were able to administer some of these clinical scenarios, especially for OSCEs and for clinical vignettes. For certain items, we were able to kind of capture the same items in both the OSCEs and the CVs, but some other things did not lend themselves well to being captured in a clinical vignette as compared to a OSCE. When I mean OSCE, I mean the use of the mama nutty dolls and simulators. So providers were much more likely to list out certain items that they're supposed to be doing when they were performing with the simulator. But for most of the key indicators, there was no difference between the simulator and the clinical vignette. So for example, say for the neonatal resuscitation scenario, the number of providers who listed the aspects of taking the APGAR score were equivalent for both the OSCEs and for the CV. Similarly, for the third stage of labor, the administration of oxytocin within 1 minute was kind of very similarly reported across both the assessments. Some of the key things that as I mentioned previously, that did not come across well enough in the clinical vignette are these expressions of empathy, like trying to, the conversational piece where they kind of provide instructions to the woman to do certain things, like push, when was the time to push, or asking, reassuring her. These are the kind of things that do not come across well in a clinical vignette, because as you can imagine, they don't have that visual cue of a patient in front of them. Does that clarify, Louis? And we will discuss a bit of the logistics as well again.
Yes, it does. Thank you. I mean, I'm just trying to, I concur with the colleague who suggested that this vignette, having vignette incorporated in the supervision system of the ministry is a good way to standardize the measurement. I'm aware that the supervision system in the for the Ministry of Health in Mali, or ICCM, for sick children, when the supervisor goes to the village and supposed to assess the community health worker, they do case management for a sick child. And when there is no sick child, they run a scenario. But to my knowledge, there is no standardized scenarios. There's no written scenarios, so it depends on the supervisor. And if you have that standardized in the system, it would improve, I think, the measurement and have a unified measurement. So having vignettes, I think, in this way would is a good way of measuring the quality of care repeatedly, because in this case we have the quality of care tool. It could be done only once in the project lifetime, as opposed to a supervision. You know, healthcare providers needs to be supervised maybe more than once, twice, 3 times in a year. So throughout the project period, you will have an ample opportunity to measure any improvement, and you can change these scenarios over time also. The point here is that to make it standardized.
Thanks for that insight, Louis. That's great. So just to close out this, one of the key things that we are not able to measure through these scenarios is a concept of respectful and is a concept of respectful care. Like this is kind of responding to Charles's question about these scenarios, because we are unable to know if a lot of the respectful questions are from the perception of the woman and kind of things that happen in certain situations, right? Like physical abuse or verbal abuse. So these are not captured by these scenarios. These scenarios are great at capturing the technical aspect of many of these, the technical knowledge of many of these interventions, but not the concept of respectful care. But again, counseling, it might be useful even in counseling to kind of gauge the level of counseling skills of the person, of the provider, basically. So I know we're running behind schedule. I'm going to quickly move on to the next slide. And we have a few slides to cover. So this is kind of a quick matrix of some of the methods that we discussed today and some methods that we have not discussed today. For example, we did not discuss the chart review or simulated client, which we will be covering in some of the other sessions where they are more relevant. And we wanted to get a quick gauge of everybody's opinions on these pros and cons. Anybody have any opinions about some of these things? I know the direct observations do cost a lot of money, so all the dollar signs pointed at. If there are no questions or feedback, I'll move on to the next one because we'll have more quick questions here. So one of the key tools that we have as part of our radar tools is this the sample size calculators. If you on the website, you can see there is a specific link to the sample size calculator where we have provided certain instructions on how to go about doing this, and we have provided two different Excel tabulations. One is to do the precision level of sample size calculation. The other is the detectable difference. So precision is usually when you have just one group, one intervention group, and you want to know how well is the quality in that particular group. So it's a single sample. The detectable difference is to kind of see when you have a comparison sample, you want to know if there is a difference between those two samples. So this could be either an intervention and a control group, or it could be baseline estimates and endline estimates of the same group. So you need two groups here to be compared. So each of these sample size estimates are based on those particular calculations. So we've kind of divided into three different scenarios. One is the scenario where we know the number of where the unit of analysis is the facility. For example, we want to know the number of facilities that have at least one provider, or the facilities that are available 24 hours. So basically, we need to enter the number of facilities that are available for us for the sampling. Then what is an estimated prevalence of whatever indicator that we are looking at, and what is the precision of that indicator. So here we have put 50% because 50% usually requires the largest sample size. So we are being very conservative here. So if you feel that the indicator that you're estimating is 90%, you should go ahead and put it in as 90% and see if that's the what the sample size for that is. And the precision, we've used 5%. So 5% basically means an uncertainty of almost 10%. So it could range from 45% to 55%. If this were 10, it would go from 40 to 60%. So if you keep increasing the width of that precision interval, we get more and more unreliable estimates. We don't even know where the actual value is. So that's one of the reasons why we've gone with a much smaller precision for this. Next is the design effect. The design effect is primarily based on how we are going to be sampling. If you know all the facilities in your sampling frame and you do a simple random sample, then your design effect is 1 because you're going with a simple random sample. But there may be instances where you may think, okay, I have 10 districts where the program is taking place. I cannot go to 10 different districts to assess the sample, to assess the program. I would rather go to just five districts and probably do a greater number of facilities in those 5 districts. So in that case, because of the kind of multi-stage sampling that you're going to be using, your design effect goes up. So here the design effect may go up from, like for facilities, it may go up to say 1.5, and in some instances may go up to 2. So your sample size kind of increases accordingly. So this is just a quick, I'm going to quickly walk you through a few sample size scenarios that that might be relevant for you and for you to take a look at to make your decisions. So say, for example, for a facility level indicator where the prevalence is around 50%, you need to go to just 80 facilities. If you have 100 facilities, but you need a desired precision of 5. But if you do a multi-state sample, you might have to end up going to 89 facilities. So you might have to go to 80 facilities in 10 districts or 89 facilities in 5 districts. So you probably need to make that decision based on the resources available and some of the other contextual issues for your intervention. So these are some of the different sample size considerations that you need to take, and the numbers that we have kind of walked for, numbers we have calculated for some of the different indicators. I think if we share the slides, I think we should be able to kind of take a look at some of these. Basically, this is a scenario where we look at different sample sizes if the indicator were 50% or if the indicator was 30%. So if you think of it, 30% and 70% are symmetrical. So 30% is equivalent to 70% and 10% is equivalent to 90%. Basically, it's the complement of 90% is 10%. So these are the kind of sample sizes. So the farther you move away from 50% for the prevalence of your indicator, the smaller the sample size gets. And similarly, the indicators that you can calculate using the same Excel sheet, say for a provider level indicator, you could do the same kind of estimates using different design effect considerations. So this is something that I wanted to quickly touch upon before we wind up in 15 minutes. Is that there are some of these logistical issues that are associated with some of these assessments, specifically with the direct observations. We need to have a significant amount of deliveries. Otherwise, it's the probability that you may never see a delivery is quite high at some of these low volume facilities. So we've kind of arrived upon 2 or more as kind of that benchmark beyond which we would like to assess facilities. Like if it is below, if it is 2 or 1 per day on an average, there is a good possibility that you might spend a week at the facility and not see a delivery as well. And in many instances, researchers may have to stay overnight as well, because some of these interactions might stretch on for many, many hours. And if we constrain ourselves that they have to return back to the base in the evening, then there is a possibility that we will miss out some of the deliveries that usually end up happening at night, which is when the quality might be suffering as well. So this kind of works into the amount of work days that are needed to be devoted to certain facilities and the willingness of researchers to stay there and kind of collect data as well. More importantly, for these, the researchers need to be either clinical providers, nurses or doctors as the case may be. So it's a question of higher per diems. And more importantly, it's about training them about non-intervention. Basically, what that means is, what do they do? Like sometimes clinicians find it difficult to not intervene in a situation where they think some error is happening, right? So we want them to be non-interventional observers. So that needs to kind of go into the training as well, and it kind of takes a little bit of practice and kind of working out different protocols as to how to respond in certain situations. And again, if there is a life-threatening medical error that's happening, then what's the protocol for intervention? Because intervening also can give rise to a lot of other issues around like the provider may feel threatened that somebody is intervening in their work, and we need to kind of work out some of these protocols. What are the best ways to handle them? So with the ASCIIs, each scenario can take almost about 20 to 30 minutes. So doing about 4 scenarios will easily take up about 2 hours of a provider time. And adjusting this within the work schedule of the provider is going to be the key struggle. In many instances, which is in many, during our testing, we actually timed ourselves to start at the end of the facilities around the 11 a.m. mark, so that we would miss the morning rush of clients, so that providers, we didn't waste time waiting there in the morning when the providers were very busy taking care of the crowd in the morning sessions. Then we had to work around the gaps in the flow of clients to kind of administer these scenarios. So sometimes these took place in chunks, because many instances these were the only provider in that facility, and we had to kind of make sure that we were not interrupting the delivery of care. So use of OSCEs, we also need that extra space and room to set up these simulators away from prying eyes. So it's key to kind of understand how the setup is before we go. It's sometimes difficult to do this if it's a one-room facility where you cannot possibly set this up, or make other arrangements to like say a room at somebody's house that's nearby to do these kind of things. Ideally, a researcher can do only about 3 to 4 providers in one day. Otherwise, they kind of start feeling mentally very tired even with this. And so for large facilities, we'll probably need extra many budget days, or even more number of simulators and more number of researchers. And the key thing to remember is we will be measuring only those providers present at the facility on the day. So we need to keep adjusting our work schedules to make sure we get as many providers as possible to take some of these assessments. So these are some of the broad budget overheads that we captured for a recent Tanzania study. About 1/3 of our total cost. Our total cost was somewhere around 95,000, and about 1/3 of them was field costs. This is field cost for just about 24 facilities, and the duration of data collection was spread out just 3 weeks. About 1/3 went in terms of consultancy and salaries, fees for the research organization, and a quick breakdown of the other buckets of expenditure. So kind of the key variable cost is the field cost. So if you think about it, of 95,000, 1/3 is kind of amounts to about almost $33,000 to $35,000 was spent to capture data from 24 facilities over 3 weeks using 2 teams. So that kind of gives you an estimate of the scale of our operations for this. Although we did it in just over a 3-week period because it was quite intensive, ideally the field work can last 30 to 40 days. Like, we would not advise for more than 40 days because fatigue sets in. Less than 20 to 30 days means it's not efficient to train large number of teams for them to just work just a few days. And for the first week of work, we do need to budget a lot of time, because we may even have to stop field work and debrief them after their initial encounters, initial assessments, so that if there are any issues that need to be fixed with the tool or the electronic forms, you need to fill them up. You need to fix them. And again, quality assurance is key. Many of these assessments actually took place in the field on paper. And the assessors would come back to their base and can enter them into the electronic forms on that day or the next day. So we need to kind of factor those timeframes in when we calculate the amount of time needed as well. So it is important that we do that. Otherwise, we will not be able to monitor the data collection process in real time. It would be quite difficult to do that. A quick word about training. Like, we should preferentially involve regional and district management and plan for at least 7 days of training, and kind of make sure that we involve the district because it gets that buy-in as well. And one of the key things that we realized was if we could divide the teams into special roles right up front, it would be good for them to kind of specialize into some of their roles. But all this depends on the number of teams that you have and the number of researchers that you have per team. I apologize, I'm going a little bit quickly without pausing for questions, but I'm going to close out now. I'm going to stop talking, and this is the point that I would invite folks to kind of provide their feedback. Please use the Google Documents to provide feedback as well. Contact us if you'd like to provide some specialized feedback that we can discuss over Zoom or by phone. And we are always available to provide feedback feedback to your future plans to use these tools and provide any kind of limited technical assistance from our side as well. So I'll leave the floor open for the next 5 minutes to kind of see if there are people who might want to provide any feedback on the budgets, logistics, and sample size issues.
Yeah, it looks like we have a question, or we had somebody raise their hand.
Sure. Please.
Oh, maybe they've disappeared.
Oh. Any questions on any of these? And even if they don't pertain to these, but they do pertain to the other areas of intrapartum care assessments, please do let us know. We can provide as detailed feedback as possible. Melissa, Elizabeth, and I were quite intimately involved in the process in Tanzania. We were there during data collection and during the dissemination process as well. And we have a member from the AMREF team join us today as well. So feel free to post any questions, and we'll be more than happy to kind of provide the responses.
And this is Jessica again here, just while we're waiting for folks to come up with their questions. What I'm going to do momentarily is I'm going to project my screen, and I'm going to share with you all here the email addresses of folks here so that you can follow up directly if you'd like. We'll also be sending those and including them in the email as well. Mm-hmm. So I'm just going to do that now. So you can see here some of our colleagues who shared as well, Diwakar's email, as well as our other colleagues from JHU, if you want to take note of their email addresses to follow up. And again, we'll be including that in a follow-up email that will go around, where you'll also have an opportunity to share any feedback that you have. I posted the link again in the chat, so feel free to solicit any feedback or comments from others in your teams as well, and pass that on. So with that, I'd just like to give my thanks yet again to JHU. Thanks to all of you for making the time this afternoon. Have a great rest of your day, and hopefully we will see you next week.